Well, good morning to everybody who has joined this symposium in National Thrombosis Week, where we are looking at how we can improve VTE risk assessment tools and also compliance across the United Kingdom. I'm starting slowly because people are still joining us. I am Professor Beverley Hunt. I'm the founder and currently co-chair of the trustees of Thrombosis UK. I'm really delighted this morning to be sharing the chairing of this session with Professor Roopen Arya, who also is a Prof of Thrombosis and Hemostasis at King's. And you'll be hearing a lot from him later, but it falls on me to get this going. I just want to say to Joe and all the other organisers of National Thrombosis Week how brilliantly organised it is, and we have over 2,700 people who've registered to join us for these symposiums. They may or may not come live, but we know that the majority of people who view our symposiums watch them in their own time later. So the rules of the game today are you may have questions, and please, would you put them in the questions and answers? We will go through them after each individual speaker, and then in the session at the end, we have about 20 minutes where we can discuss some of the current issues that exist that won't be covered necessarily by the lectures. So I know that we've got attendees from 58 countries who've joined us, and that we are going to discuss what's happening in the United Kingdom. And it may surprise many of you to know that we manage thrombosis prevention very differently in each of our 4 regions. So we're going to hear from a representative of each region, and you can get a flavour of how different it is in the different regions. So we're going to start off with NHS England, National Health Service England, and I'm really delighted to be able to introduce to you Ethel, who is leading in our Department of Health in delivering VTE prevention in NHS England. So I would like to call on Ethel Oldfield to talk to us about currently what's happening in NHS England and VTE prevention. Thank you, Ethel, for coming.
Thanks, Beverley. Thank you very much, and welcome everyone. And a chilly but sunny start here in NHS England. So I'm Ethel Oldfield. I'm one of the heads of patient safety at NHS England, and I have a varied role, part of which is looking at VTE across England. We run a National Patient Safety Committee, which has members from all the national organisations in England. So, for example, NICE, Department of Health, the Care Quality Commission, some of the Royal Colleges. We try and have coverage from all the main bodies across NHS England. So just around COVID time, we started to look at some of the bigger problems in the NHS, and it was decided as a group that we would look at NHS England. That we would look at VTE as a group. So we asked all the organisations to look at what they were doing in terms of VTE prevention. We had paused the national VTE risk assessment data collection just at the start of COVID. So for those of you who are not in England, there was a sequence, which was a policy that was decided back in 2010, that all patients had to be risk assessed for VTE once they were admitted as a patient to an acute hospital. This carried on and has been running until just pre-COVID, which was paused to just release staff and to release some time. Following the group discussion that we had at the committee and some stakeholder involvement, it was decided to restart this data collection process for any of you who has ever had to start anything that involves a whole country, it takes forever to get anything done. So we had a lot of work to do behind the scenes and a lot of stakeholder engagement to restart this process. We were concerned that maybe doing the data collection on a risk assessment might not be the best of things to be asking people to do. However, feedback from the system was very clearly people wanted this to restart. We did suggest adding more questions. So, for example, we considered adding questions like, was the VTE assessment completed correctly? If VTE thromboprophylaxis was required, was it prescribed? And if it was prescribed, was it given? However, given the status across the country, or the different statuses in terms of electronic patient records, the financial burden would have been too big. So it was decided to restart as was. The only change we made was to sit in line with NICE guidance, was to have patients risk assessed within 14 hours of admission. So that was restarted in April of last year, with the first collection started in July, and we published the first. We had a delay in publishing the data because NHS Digital was amalgamated into NHS England and teams had changed, so it took some time for this to be picked up. It was released in I think it was in December, the first 3 quarters. We have still and are working behind the scenes with a number of organisations. We're still having lots of queries and discussions around the data collection. And we are delighted, in fact, very delighted, that the first quarter from 23-24, the risk assessment rate was 89%. Second quarter, that went to 90%, and then the third quarter went to 91%. The fourth quarter is currently being analysed by the team and should be published, I think it's late May, early June. We are still working with organisations, particularly around the 14-hour mark, trusts who are not who are not electronic, i.e. if they're paper-based, because it's been a new thing to restart, where previously they had resources in place to be able to do this audit every month. Once they stopped, they lost that resource, so some are still working to get that back up again. We have made some reiterations to the data, and we will continue to do that as time goes by. So from a national perspective, that's where we are currently. There is me as a very small part of my job is to look at this. There obviously has been an announcement around NHS England and Department of Health, so whilst this work will continue because it's really, really important, we would desperately like to have an improvement programme around this, because as all of you are here, we have hundreds and hundreds of people having this discussion this morning, and there is so much more work to be done. If there was lots of time, I could talk to you about some of the kind of thoughts around things that are needed. So even doing something as simple as like a SEEPS model, and looking at VTE as a national problem, there are so many areas where we could work on. We need more data. We need to understand a little bit more about the numbers. So prior to COVID, the number of deaths from VTE, which is all VTE on a death certificate, was around 12,000, which increased over COVID, but has come back down to about 13,500 deaths a year. Pre-COVID, they were about 4,500 hospital acquired or healthcare acquired. So when patients were admitted with no VTE, however, had a VTE on their death certificate 90 days post-discharge. We would like to look at that data in more detail. We would also like to look at areas like mental health, like transfers of care across. So, for example, a mental health trust, and they're admitted to an acute trust with a physical problem. Coding is very, very different. There's lots of areas around medical patients. Some of the kind of raw data that we looked at just pre-COVID was looking at all the patients who were dying from VTE. Surgical patients seem to do quite well, in that there is a very robust kind of plan in place for surgery and surgery pre-assessment. But medical patients who come in unwell seem to not do as well, whether it's because the focus is on surgery patients. So if there's any of you out there who would like to do some research or do a PhD, this would be an excellent area that we would like to look at. So please do think about that. I guess in terms of, there's other areas, I think, healthcare in general, the health of the nation in general, I think, pre-COVID has probably decreased slightly. things like smoking, obesity, all the kind of normal things that make us not healthy are not probably doing so well in the current environment. Things like time. Do staff have time to be able to do their jobs and actually do these risk assessments properly? I think patients, do they really understand the risk? I know there's some issues around patients don't particularly like taking thromboprophylaxis because it's often an injection, and that is another area to be explored. I think in terms of technology, that's a big issue. Trusts who are not electronic patient records, where they're still paper-based, are really, really struggling with this data collection, but also some are struggling with the risk assessment because it's paper-based, and then it gets filed. How do they make sure that that is complete as appropriate? I know there's some work being requested into NICE to look at the guidelines. Lots has changed, I think, since the most recent update, so that will be something to look at. I still think there's a lot of work to do. We would, like I said, we'd really like an improvement program. Our hands are a little bit tied at the minute, so if any of you have any extra money or you've won the lottery and you'd like to share, we would really like to take this forward as an improvement plan, because there is a lot of work needed in this area, and the fact that we're all here having this discussion, I think, says it all. So I guess for now, are there any questions?
Well, thank you, Ethel. I think for those other countries that don't know our system, it was in 2010 that we demanded that every patient that was admitted had to be risk assessed, and we had to inform the centre, the Department of Health. So this is a census. This is not an audit. This means that we all have to return what we're doing with VTE risk assessment to Ethel's department. And of course, this is easier with electronic risk assessment. It's not easy with paper. I'm going to bring in Roopen here. Roopen, do you have some questions?
Yes, thanks. Thanks, Ethel, for that update. I mean, I think the reinstatement of the VTE risk assessment data collection is very welcome, because I think it's central to our efforts. So there is a question, unsurprisingly, around the 14-hour capture mark, because as Natalie Heaney comments, in their hospital, the times, starts from admission to the inpatient ward rather than the decision to admit. And we are aware that across the NHS, there's a lot of pressures to get patients out of ED. So now there's SDEC areas, for example, same-day emergency care, in which quite unwell patients are looked after. So would you like to comment on, how we can refine this 14-hour cutoff? Because I know many people have a problem, with the definition.
Agree. It is a difficult one. We did have some discussion prior to going live with the data, to reinstate the data collection, to have it as decision to admit, which would mean from ED. And like I think Natalie has just said in the chat, lots of patients are waiting for beds for so long. The kind of criteria for admission, we haven't specified as such. It is in the NICE guidelines, so we have left it at that. So the NICE guidelines currently states that patients should be offered prophylaxis within 14 hours of admission. Therefore, if they're administered, given thromboprophylaxis, they should be risk assessed prior to that. So that is where we've come about with the 14 hours. We haven't actually said from decision to admit, we've said from admit. I think it would be excellent if we could do it from decision to admit, because by the time patients come to ED, particularly medical patients, they may have been unwell at home for some time. They may have been waiting for an ambulance for some time. They could have been in the waiting room for quite some time. So by the time they're actually a decision to admit, they could have been unwell for a number of days. So actually the risk has increased significantly. In terms of any suggestions, I don't have one, to be quite honest. I think it is very, very difficult. I think the one thing we have found with the discussions we've been having with so many organisations in the last couple of months is the fact that this has been reinstated has helped their case in terms of the electronic patient record and changing their systems, where things have been kind of, oh, we'll do that at some point. Actually, they need to start doing it sooner rather than later. It is very, very difficult. I know some organisations have had staff where they've got undertaken this piece of work from admission, from as soon as they're discharged. So if the patient records are paper-based, that they've got somebody to review those prior to them going off to storage. I don't know that there's a magic bullet for this. If anybody listening to this has got some suggestions for this, please pop them in the chat, because I think this is an issue across the board. Organisations are struggling. NHS is really, really busy, as I'm sure all the regions are that we will hear from today. I think Kevin has time the bed was requested. So exactly, there may well be areas here where others who are in this position have been able to manage this, but it is a difficult one, and I'm afraid I don't have a magic answer.
So there's no proposal to change the way we capture it anytime soon, because there's probably a bit of gaming of the system as well.
Absolutely.
And, it would be nice to ensure a level playing field, but I think the bottom line is that it's a good thing to be able to capture the data, because it's an important driver locally as well.
It is, and we have seen like those slight increases, 89, 90, 91%, and the very fact that it has been reinstated has re-shone a light on VTE, which will help build cases to try and improve this as well.
I think clearly there's lots of work to be done under the surface. For example, the day surgery cases, which as more and more of the surgery is now being done as day surgery, and sometimes quite major surgery, but in most hospitals that would not be included in the data that they submit. So yeah, so I think it's a great first step to get it back on, but I think a bit of work on kind of refining what underlies it. Yeah, so I'm sure we are going to there'll be a lot more discussion around this in our panel discussion later. So I'm aware of time, and we do need to move on. So no doubt we'll come back to it, because it is, I think, a big issue. So thanks, Ethel. So the next speaker is Dr. Gary Benson, from Belfast, Northern Ireland. Again, Gary has been a big champion of VT prevention, and we have worked together in this area for many years. So welcome, Gary. Over to you.
That's great. Thank you very much, Roopen, and thanks Beverley and Joe for the kind invitation and inclusion of Northern Ireland. It's kind of nice going in the middle, so I don't kind of feel too backward as a country compared to the advances that everybody else is ahead of ourselves. So what I kind of want to do is to give a little bit about, I think the main difference with devolved health in Northern Ireland is that targets such as sequins don't actually exist. So there is no central push with regards to quality or quantifying such things as ensuring that there's a risk assessment that has been done for VTE. Where most of this will come from is really purely the NICE recommendation. Therefore, we will follow NICE within Northern Ireland, and this is one of the areas that we look at very keenly. And even our coroner looks at it very keenly as well with regards to ensuring such things as cases of hospital-acquired thrombosis where death has arisen. The coroner's team are very keen to find where considerations for risk assessment have been undertaken. What I want to do is just to go back a little bit with regards to our history. Northern Ireland will have 5 healthcare trusts. each of those trusts have that ability to have undertaken the risk assessment historically as they have felt they wish to do so. It was also undertaken separately within each subspecialty, within each trust. Therefore, several years ago, up to about 10 years ago, we would have had different medical, surgical, and different even surgical subspecialties that would take different aspects of risk assessment whenever they were introducing it. Around about the same time, there was a concerted effort nationally within Northern Ireland to actually have a centralised single drug cardex, so that if a patient had to transfer between trusts or transfer into Belfast, which houses the majority of the subspecialties, that actually that cardex could travel with the patient. There was a harmonised health and care number that all patients were given. It became quite clear, therefore, that actually one of the ways to try to standardise the risk assessment would be to introduce it into our regional or into our national drug administration cardex. So a lot of work was undertaken with regards to standardising the information that was to be included with the risk assessment, which is much simpler just to take the standard tool that was already recommended throughout the whole of the UK. So with the advent of the drug cardex coming in, then this was something that had to be physically reviewed and assessed. So within our own trust, within the Belfast Trust itself, we have 5 separate hospital sites. So each of these sites will take up different aspects of clinical care. So we'll have one of the sites which is dedicated to elective orthopedic surgery, another site that is our mental health acute inpatient unit, and then the other sites themselves will take over some of the different subspecialties of medicine and surgery, as well as incorporating maternity. So within the trust itself, this accounted for approximately 1,100 beds at any one stage. So from our perspective, our VTE nurse champion team, who will look after the outpatient VTE service from patients diagnosed within the ED each month, would have done a bedside check of each inpatient within the trust itself. So it's quite a lot of work. I think the main advantage that we found with this piece of work was actually to have the nurse specialist within each ward and interacting directly with the nursing and the medical team. So at the end of each audit cycle, whenever the ward was undertaken and with the nurse there, then it was able to be directly fed back. So in general, this really was a main focus with regards to driving up compliance. So at its best, compliance against the 1,100 inpatient bed, including acute mental health, was around about 93 to 95%. Maternity at that stage follows the Royal College of Obstetric guidelines, and our obstetric patients would have physically carried their own notes. So it was not as straightforward for us to have them included at that stage. The cardex risk assessment excluded obstetric patients, so there was still that gap there with regards to maternity. The main issue at that stage that we had fed back to us in trying to improve the risk assessment was the fact that it was actually placed in the cardex itself. This was very much viewed as being something that only the medical team were able to undertake, because it seemed to have been linked with the prescription of drug or medication. And we did a lot of work with regards to our ward-based pharmacists who were able to highlight cardexes that were incomplete, highlighted it with regards to our nursing staff whenever they were doing a medicines round, that if it wasn't complete again, to have that set out for the medical team to have it completed. The only thing that we couldn't do was the fact that once the cardex was actually complete with regards to daily follow-up, there was no additional documentation available to ensure that actually on an ongoing basis that this was updated and maintained. So very much that if it was complete, it was completed at the time of admission. The cardex itself lasted for 14 days. So if there were some patients who were in longer, then that, whenever the refreshed cardex had to be rewritten, then again, that was the opportunity whereby the risk assessment was reviewed and repeated. So that was kind of where we were at. Our main challenge with regard to the specialties tended to be those specialties who were already prescribing low molecular weight heparin to treat a clot, and this was predominantly within a cardiology subspecialty. That very often what would come back would be a very low compliance rate with regard to the completion of around about 50 to 60%. But whenever you would look at the Cardex, low molecular weight heparin was being prescribed. So we were constantly being told we don't need to risk assess because our patients are already on treatment dose low molecular weight heparin. We tried to highlight to them this was incorrect, that they weren't showing an intention or they weren't showing an awareness of the risk of VTE. Whilst that may be the case as an inpatient, it was not necessarily the same case whenever somebody was coming out to be discharged, whenever the low molecular weight heparin may well have been discontinued. So we got very familiar with the Cardex-based system, with the Cardex-based audit, and the monthly figures, and that was improving. So as with many of you, you may be facing now with the electronic paper record, or the electronic, the sort of paperless system. So this has now been brought into Northern Ireland. So to date, 3 out of the 5 main trusts are now completely paperless and are using predominantly the IT system. The remaining 2 trusts will go live at the beginning of June this year. Therefore, for a region, all secondary care trusts are signed up to the same system with regard to the recording of it. So what we have now found is, whilst it is convenient and much easier centrally to double check who has actually completed the risk assessment, that you can simply ask the system that question and then you will get the figures by ward. I think it removes some of that personal touch by going to the ward itself to look at the figures and to give them direct feedback. However, it has certainly benefited the time of our nursing team. But I think that the one thing that we are finding is the override and accept function that actually is coming up whenever many alerts are coming through these types of systems. Our trust safety group is noting this need to please the system, whereby everybody will override and accept and not necessarily pay too much attention to actually what you are overriding or what it is that you are accepting. So whenever it has come to the VTE risk assessment, whenever we went live in June of last year, VTE risk assessment actually plummeted. And it dropped significantly because it seemed to have been something that, whilst there are a lot of reminders, it was getting mixed. It was getting mixed in with all the other reminders, and really its priority was no longer being adhered the way that it had been before whenever we were measuring it. We have tried repeatedly to consider things like what's referred to as a hard stop. I'm sure many of you that use the systems will be aware of it. So is it possible, therefore, whenever somebody is actually being admitted to their ward, that actually you cannot go beyond the risk assessment, you cannot prescribe any medication until you have actually completed it? I'm aware of the many schools of thought of this. I think sometimes that it's just, if it is managed so aggressively like that, that people will simply just try to please it and just to do it, to move on, rather than necessarily paying too much attention to actually what the risk assessment is, simply to move on to prescribe the other drugs to move it on. So it's the one thing we think that with the next 2 trusts going online with the IT system come June, that we're probably going to have to do a lot more of a focus with regards to this type of hard stop in order to push the completion. It has improved, and we have seen month on month that each individual ward within our own trust has improved with regards to its risk assessment. We still have the old chestnuts that are still there, that haven't really changed with the IT system that they didn't do with the documented Cardex. But I do think that the other bit that we're now trying to do, that undoubtedly you're well ahead, is to try to join together risk assessment with hospital-acquired thrombosis, and to try to see actually that if we find the clotting events happening, then trying to feed that back to the wards, not as a stick to beat anybody with, but I think sometimes just to highlight individual medical and surgical specialties, because sometimes these patients, as we know, don't get admitted back to where they came from, and teams may not ever have been aware that these events had happened. So I think that in summary, our journey had been with a documented risk assessment built into the Cardex with face-to-face feedback on a monthly basis had definitely given a focus to the ward alongside other things like wound care and pressure dressing that we get to hear a lot about because it has been a real trust focus and perhaps not so much risk assessment. To now having an IT system with its own challenges. It had often been sold to us that this would be the great savior and it'd be really easy. And of course, it'd be 100%. How could you not complete it? To actually the reality of going that actually it's presented more of a challenge than actually a solution to getting these risk assessments done. So that's kind of where we're at, Roopen.
Yeah, thanks, Gary. That was very helpful. Yeah, I think it raises a lot of issues, around, number one, electronic risk assessment is said to be easier, and we don't have an oversight over the proportions, electronic versus paper. Nationally, there's no good data. But, equally, I think changing to the electronic format is not a kind of universal panacea, because Beverley and I work in trusts in which this has happened in the recent past, and it initially significantly dented the risk assessment figures because it was not being captured as robustly. And secondly, we also had this discussion around the hard stop. And I think ultimately, our clinicians and the stakeholders requested the hard stop as the only way to make them do it.
Yeah.
And then it links to the electronic prescribing. So I think it does all fit together. But I think an all singing, all dancing system that will enable us to robustly risk assess as well as identify the cases of hospital-associated thrombosis is still a long way away, I think.
Yeah.
Okay, again, there's a lot of questions around the timing of this, but I think we'll pick it up again in the kind of panel discussion. I'll hand over to Beverley.
Thank you. And for those who don't live in the United Kingdom, or for those who live in the United Kingdom don't know, just to remind you, the populations of the countries are very different. So England is 57 million. Northern Ireland is 1.9 million people. We're going to hear from Wales next, 3.1 million people, and Scotland, 5.5 million. And it does seem extraordinary that we can't all get together and have the same healthcare system. But we have maintained our regional differences, and it's been interesting. So let's go on now to Wales, and the Welsh have had a very different driven system for VTE risk assessment. And I'm delighted to welcome Christine Welburn, who is has a background in nursing, who is now leading on VTE risk assessment in Wales. And she's going to talk us through what has happened and what is happening now in Wales. Thank you very much, Christine, for coming along.
You're welcome. Thank you, Beverley. So I'm Christine. I used to be a specialist nurse in VTE prevention. I now work with the Welsh Risk Pool, leading on the VTE Wales programme. So for those of you who don't know what the Welsh Risk Pool is, it's the indemnifier for health bodies in NHS Wales. It's hosted by the NHS Wales Shared Partnership, and the Welsh Risk Pool adopts an integrated approach to risk management, claims management and learning to improve. So the Welsh Risk Pool team do work with the Welsh Government, the NHS Executive and NHS colleagues across Wales in the aim to promote and facilitate opportunities to learn and support the development and implementation of improvements aimed at enhancing patient safety, staff safety and clinical outcomes. So I think it's important to understand where we are with VTE risk assessments today in our current practice is to understand how we got here in the first place. So back in 2008, there was a national programme called 1,000 Lives, which was an improvement programme across Wales looking at high risk areas and implementing improvements. And heart prevention became part of this 1,000 Lives programme. And so for the heart prevention side, 1,000 Lives created several different VTE risk assessment tools. And these was different tools for different specialities. And this was on a national basis as standardised risk tools to be used in every health board across Wales. So we ended up with about 7 different risk assessment tools in practice. And then in 2012, the Welsh Government held the one-day inquiry. 2014, an All Wales Heart Committee was formed. 2015, there was quarterly submissions of heart data was to be started to send to the Welsh Government. So this made VTE prevention a tier 1 priority for all health boards in Wales. So we had to do national reporting to the Welsh Government, and then we also had the 1,000 Lives programme driving it on a standardised national basis as well. And then 2020, we had an All Wales Thromboprophylaxis policy produced. And then in April 2021, when the delivery framework for 21-22 was published, it had removed the quarterly reporting requirement for heart data to Welsh Government. So this meant that it was no longer a tier 1 priority. We no longer did national reporting for our heart data. And a few years before this, the 1,000 Lives programme ended as well. So we had no national drive. So this was a massive turning point in our processes and how the health boards went forward with heart prevention. So it's up to each individual health board to decide on what the priorities were. So some health boards kept it as a top priority and still kept the resources in place for VTE prevention team to carry on the work and the reporting, and some health boards didn't. So this is where the variation started. But what also happened in 21 is that the Welsh Risk Pool started to look at VTE and HATs as well, because the National Learning Advisory Panel identified increased numbers of matters relating to VTE. And they requested the Welsh Risk Pool to do a national review of patient records, which was done across all health boards. And that had 5 outcomes included in the VTE review, which was issued to all NHS Wales health bodies. So in 2022, we had action plans submitted to Welsh Risk Pool with commitment to address all the review outcomes from the review from all health bodies. We created 2 VTE e-learning modules that was available to all staff. And then in 2024, the Welsh Risk Pool created the VTE programme strategy, and that was commenced. And in 2025, we've just completed the VTE scoping exercise across all Wales, and this was a review of our progress and what our position is across Wales. So the VTE programme that's been developed by the Welsh Risk Pool is to follow up on the outcomes and recommendations from the 2021 review. The VTE programme also aims to support the national reporting and collection of heart data. Now it's no longer reportable to the Welsh Government. And in regards to our VTE risk assessment tools, the scoping review that we've just done is just highlighted. We currently have 35 different VTE risk assessment tools being used in practice across Wales. And although we've got a lot of different risk assessment tools in practice, I think it's important to note that actually they're all very similar, because they're all based on the original 1,000 Lives risk assessment tools, but they've just been further locally adapted by the teams over the last few years. And the compliance in completing the VTE risk assessment tools varies significantly across the NHS Wales, and the big deciding factor on this is whether the health board kept it as a priority and whether they have a VTE prevention team still in post carrying on with this work. So the ones that did have higher compliance compared to the ones that didn't. There's only one health board in Wales that's currently using electronic prescribing, and they have experienced both pros and cons to this. We do have 7 health boards across Wales, plus we have Lindra NHS Trust, which is our big cancer centre. And it's highlighted that we need consistency and education is needed, so that risk assessments don't become a tick box exercise. So our next steps for VTE Wales is to discuss the VTE scoping results with all our VTE specialist colleagues and clinicians that we're working collaboratively with. We need to determine what the requirements for risk assessments are in practice. So we need to review all our current risk assessments, and we need to reduce these down to the appropriate number. We need to develop and roll out standardised risk assessment tools across NHS Wales. We need to ensure that all Wales VTE risk assessment tool is incorporated into the electronic prescribing implementation plan. We need to update the VTE learning packages with the aim to enhance the risk assessment completion. And we're also working with the NHS executive to ensure that national HAT reporting and visibility for NHS Wales. So our current potential barriers and challenges are electronic prescribing is going to be gradually introduced from this year. So that means that we're still going to have a mixture of both electronic and paper systems for quite some time. We've got the time requirement to develop and agree the All Wales risk assessment tools. That's going to be a massive task and a lot of time and effort from everybody to review the risk assessment tools. And also that not all health boards do have a VTE prevention specialist team in post. So that is another challenge that we have to work around. So moving forwards with implementing changes in Wales, we've said it has to be patient focused. We want it to be led by a national team. We need to reduce the variation. We need 100% need it to be multi-professional working. We need education. This is both for staff and patients. We need communication and awareness of VTE, and that again is for staff and patients. We want national HAT reporting, commitment to continuous improvement, continued feedback and sharing of lessons learned. So we want it to not just be health board wide, we want it to be nationwide. And we're also really looking forward to getting electronic prescribing as well. So we're heeding the words of Socrates, who said, secret change is to focus all of your energy, not on fighting the old, but on building the new. And this is what the Welsh Risk Pool VTE programme is aiming to do, to address all these points and create a long-lasting benefit for patients' experience and outcomes. So in conclusion, this is a really exciting time to be working in the field of VTE in Wales. We're creating a national approach to drive best practice, improve patient safety and outcomes, as well as a multi-professional approach to learning and sharing VTE practice across our organisations. That's it. Thank you for listening. That's my email if anybody wants to contact me.
Well, thank you so much, Christine. So it sounds, I remember being part early on of VTE risk assessment, and the system became very well developed, and then the focus of the managers came off VTE, is what you're essentially saying. So now you're rebuilding again and modernising. Yeah. Can I ask you that vital question? Are you going to go for a hard stop with your electronic prescribing?
Yeah, I think the majority of health boards have already discussed this with the programmers and they have gone for the hard stop. But I think what we're seeing already in Wales is that with the hard stop, we're getting the compliance, but it's not necessarily making the prescriptions correct. I think that's where the education and awareness comes in.
That's a great point. And do you have funding to produce your e-learning tool, or is that done out of goodwill?
Mainly goodwill. I think VTE has been driven by goodwill from the teams across Wales for many years. But I'm hoping now we've got this national approach and this national programme starting, hopefully we'll get more buy-in and funding. But yeah, a lot of it is goodwill and dedication from our colleagues, really.
But there is an argument for you to get funding because your whole service is being driven by your insurers, isn't it? Your insurers are saying to the health service, you've got too many cases of hospital-associated venous thromboembolism. You have got to do something to reduce your insurance rates. So there must be a bit of money there. If you can reduce the insurance rates, then maybe your trust might give you some money. It's a bit argument to have, isn't it?
Yeah, and I think now we've got the VTE scoping done. We're in the process of writing the report, and I think that report will highlight where we are and also the way forward and what steps we need to take and what resources we need to complete these next steps. So hopefully that will be in our favour.
Okay. Can I bring in Roopen now? Roopen, do you have any questions?
Yeah, no, I'm amazed that people found 35 risk assessment tools out there.
They're very creative in Wales.
Yeah, that they could implement. And I think the other issue, which I think isn't common, just all across the countries, is the resource for the VTE prevention role and team. As the NHS is getting increasingly cash strapped. I mean, I am worried that. There was, as part of the Gulf thrombosis survey, 30% of the hospitals about 4 years ago did not have a dedicated VTE prevention role. And my fear is if we look at that again, it'll probably be more. So that is something that does worry me.
Yeah. And I think, the health boards that do have VTE prevention teams in have shown a massive benefit. You get increased compliance, reduced preventable hospital-acquired thrombosis, you get the education and staff awareness. And I think to have a team in place, although it costs money, it actually prevents you spending more money because the cases come down. So actually you're saving money by having this team, and it's beneficial to staff and patients. So I think there's a good case for every health board in trust to have VTE prevention team.
Okay, great. I think we'll pick up some of these items in the panel discussion as well. So now it gives me great pleasure to welcome Dr. Catherine Bagot, who is a consultant hematologist in Glasgow Royal Infirmary, who has done a lot of pioneering work around VTE prevention in Scotland and also has an interest in women's health. Over to you, Catherine.
Thanks very much, Roopen. And it has been really lovely to hear everyone else's experiences. I think I was quite nervous coming to do this, thinking that everyone would have all their soldiers in a row and that Scotland wouldn't look too good, but everyone is experiencing the same issues. So I've just got a few slides to share with you to really show what the Scottish experience has been with regard to VTE risk assessment and prevention. Next slide, please, Jo. So as everyone else has done, I'm going to describe the history. So we have something in Scotland called Scottish Intercollegiate Guidelines Network. You may have heard of it, called SIGN. And prophylaxis for VTE has been on its radar for many, many years. But what I want to concentrate on is in 2010, there was this real promotional launch of VTE prevention with a risk assessment tool, sort of what we call the generic risk assessment tool for medicine and for surgery, launched in 2010. Next slide, please. And there was this launch, there was real involvement of national leaders, it was supported and encouraged by the Chief Medical Officer, there was real leadership at executive level in the boards, and we have someone called the Scottish Associated Medical Directors. So this is generally medical directors at the top of their health boards, again, buy into this. Yes, we're going to do everything we can to comply with SIGN 122. And it was recommended that we should have thrombosis committees in every health board, that there should be education, that there should be data collection of hospital-associated venous thrombosis, and that there should be audit. Next slide, please. And to take this even further forward, venous thrombosis prevention was introduced into what's called the Scottish Patient Safety Programme, or SPSP. This is a part of Health Improvement Scotland, which is there to be responsible for trying to do everything that can be done to prevent adverse events to people admitted to hospital and improve patient safety and reliability of care. And thromboprophylaxis for surgical patients and for medical inpatients was introduced around this time to be part of the SPSP. Next slide. And what this was all about was the aim of SPSP VTE programme was to improve the reliability of delivery of evidence-based interventions to get down the incidence of venous thrombosis in Scotland. And what was considered the evidence-based intervention was having a VTE risk assessment tool. Just to be clear for everyone, you may see a reference made to sepsis 6. It's because the SP VTE programme was linked with sepsis, which I suspect was probably a little bit of to be as cost effective as possible, but I'm just obviously concentrating on VTE risk assessment. So the intervention was the VTE risk assessment form. A template of how that should be done was in the launch in December 2010. So you were supposed to have your intervention, you were supposed to have your non-technical interventions such as education, having patient leaflets, getting patients involved, and then an implementation. How well are we doing this? Is this intervention, the VTE risk assessment tool, being used? And the way to achieve this, it was felt through the SPSP programme, was to see if you were implementing appropriately, just in pilot wards. So basically you were looking for assessing how well VTE risk assessment done was just on pilot wards around the country. And you'd see how well you could implement it, and the techniques for implementation were then supposed to be initiated on a wider spread around more than just the pilot wards. Next slide. And what data collection did SPSP recommend? Everything we talk about, and although this slide's relatively busy, basically, have you done a risk assessment? Have you made sure that they can safely receive anticoagulants if they need to? Whatever your risk assessment said, you should then carry out the recommended action. You should reassess, and this should all be documented. Not only documented that you've done the risk assessment, but also you've told the patient about why we're doing risk assessment. And this laudable aim was to ensure that there was going to be 95% compliance by the end of December 2014. Now, from personal experience in our health board, sorry, back one slide, sorry. The real experience in our health board was that we had the help of clinical effectiveness. They tried to get nurses involved who would really promote this and would undertake this pilot audit to demonstrate that we were introducing VTE risk assessment and prophylaxis. But it was impossible to get buy-in, absolutely impossible. So many health boards trying their absolute best to pilot, demonstrating that they were getting VTE prophylaxis done, but without these champions on each ward, it was impossible. Next slide, please. So sure enough, by the end of 2012, it was just known that all that data couldn't be collected. So they thought, okay, we need to be pragmatic in SPSP. Okay, have we done risk assessment for patients admitted for inpatient care? And if so, has there been concurrent administration of the interventions such as low molecular heparin to prevent venous thrombosis? Now the timelines for those two were 95% in pilot wards, as I mentioned before, by December 2012, and 95% for all acute hospital admissions by the end of 2014. And again, it was not achievable. Next slide, please. And this is sad. And I think that everyone really tried so hard from 2010 to 2014 to really get VTE prevention and prophylaxis into the system. But without having champions in a health board going around wards, it was all run on goodwill. And this is what I mean about hearing the other speakers. It was all done on goodwill and it just could not be maintained. And what I'm showing on the slide now is this is basically the report that was issued in 2015 about how well the SPSP Sepsis VTE Collaborative, we're obviously in contact on venous thrombosis, how it went. And it was quite sad, was that really this using pilot wards and then trying to spread it out without the resource, it just could not be achieved. And what I have here is basically why they felt the SPSP program just could not work with venous thrombosis. Can you just click forward, Joe? And you obviously can't read all of these, but these are the things that I wanted to point out about how SPSP felt that this system of trying to get VTE prevention out there across all of the health boards at a level that was acceptable to all was not possible. So first of all, it was felt that VTE was imposed as a top-down initiative rather than a drive for the clinical community. I don't think that's entirely true. You know, Beverley can obviously say from, you know, this was a massive thing in the 2000s and there was a drive from the clinical community to try and improve things. Click again, Joe. I do think this next point is really interesting. And I think we've got even more of a problem with this now, is that documentation and prevention is seen as less high profile and less important. When you've got waiting times of goodness knows how long in A&E, this documentation prevention can slip away from its importance can slip away. And click again, Joe. And I think another thing that's going to come out is that where the VTE prevention needs to occur is not where the hospital-associated venous thrombosis will end up. So those that are being told, please, please, please risk assess and make sure you give thromboprophylaxis appropriately, it's not coupled to the poor patient with the venous thrombosis who presents 2 weeks ago away from that clinical area where it was first initiated. Next slide, please. So I've gone through the history. I've only taken you up to 2015. What has really happened over the last, well, what is now 10 years, is that resources have gradually been disappearing. We don't have as much input now from clinical governance as we did to try and move forward with these VTE prevention programs. And so the need for goodwill has probably over the years got bigger and bigger and bigger. And then I think the pandemic probably really made things much, much worse. But I want to end on a positive note, because what I decided to do when I was approached to give this little presentation, be part of this discussion, is, okay, things haven't quite worked out as we planned, but where exactly are we today? So when I was asking this presentation, I thought, right, we are quite a small country. We're not quite as small as Northern Ireland, but we are quite a small country. And we don't have that many people who specifically specialise in venous thrombosis. We have many, many hemato-oncologists, we have general haematologists who might have an interest in venous thrombosis, and then there are a very small number of people like myself who actually specialise in this area. So I thought, okay, let me approach consultant haematologists across Scotland who probably do have some awareness of venous thrombosis prevention and give them a very, very basic questionnaire, because I really need to encourage completion. And so I asked them, where are you with your VTE risk assessment tool in your health board? What's your compliance with completion? What sort of audit strategies do you have? And what sort of risk assessment tools do you have for specific patient cohorts, for example, obstetrics? Next slide, please. So just to give you some idea of what Scotland looks like in terms of health boards, we have a number of health boards, and you might sort of think, oh my goodness me, only 8 people responded, but actually I was able to get an overview of probably more than 4 million of the Scottish population. As Beverley said, we've only got about 5.5 million in the country. I was able to get respondents from most of the health boards in the country. It covered a range of teaching hospitals and district general hospitals. It covered large and small health boards, and it was able to cover more rural health boards compared to those that are much more city-based. Next slide, please. So as I say, I kept this really, really simple. So I said, okay, do you have a generic risk assessment tool? By generic, I mean this tool that sort of came out in 2010 that covered sort of general medicine and surgery. All of these health boards that I was able to make contact with did. And it varied in terms of paper or electronic. So 5 health boards have electronic prescribing, and they also, so as you can see, 2 of them still have paper notes but have other methods. So there's a good amount of electronic prescribing, there's some electronic notes, and there's some that only still have paper notes, but most have some form of electronic documentation. It's mandatory for 4 of those who electronically prescribe, and that is a hard stop. And I think it's been so interesting what's been said about pleasing the system. So we used to have a Cardex, as Gary described, where prescribing was on a particular Cardex, and every single time you opened it, you were reminded, alongside low molecular heparin prescribing, have you risk assessed today? And if you have you prescribed? Having the hard stop has removed that thought, oh, I just need to press some buttons so I can move on and prescribe. So it's good, but in some ways it's not good. The people who said it was not mandatory to complete risk assessment made this comment that it was very much ward dependent. So if you had champions on your ward where they were trying to, move forward a risk assessment, then they may well make it mandatory, but not as you can with the electronic system. And what about alerts? Yes, 5 had alerts. That's pretty much the electronic prescribing. But as one of the problems we've found is it's only on admission. So now undertaking repeated reassessment is very, very tricky, unlike when we had the paper Cardex. So it's not that I'm saying we should go back to paper Cardexes, it's just the electronic system has brought along its own challenges. Next slide, please. What about compliance? Is there any audit of venous thrombosis risk assessment? 7 said yes, 1 said possibly in the past. And I think that's one thing that was very, very interesting when I was approaching my colleagues around the country, is we all had this memory that everything was really, really focused from about 2010 to 2015. People were doing lots of audits, and then it's sort of fallen away over time. We're in a situation now where the vast majority of VTE risk assessment is very much on an ad hoc basis. Very much goodwill. Our ward wants to look how we're getting on, how we get what's happening in our ward. Collection of healthcare associated venous thrombosis is essentially not happening. One health board is undertaking collection of that data, but even that health board is unable to undertake root cause analysis because there is just simply not the resources. And the collection of healthcare associated venous thrombosis in that one health board is completely goodwill. Next slide. And finally, what other risk assessment tools are there for specialist patient cohorts? Everyone has one for pregnancy. It's essentially the RCOG guideline. It's quite common to have a risk assessment tool for lower limb immobilization, although I wouldn't say that we're following TRIP. And there is risk assessment tools for day surgery. Sometimes that is simply the generic risk assessment tool. Sometimes it's a specific one. Next slide, please. So just to give a summary, I think there really was, I mean, I just arrived in Scotland in 2010. There was a real national movement to engage NHS staff in VTE prevention, and I think that probably was effective. And I think that's why today we're seeing that everyone has a VTE risk assessment tool, both generic for medical and surgical inpatients, but also speciality specific. I think there is a greater awareness. And what's very interesting, of the audits I've been involved in and the audits that others have been involved in, these small ones, generally we find that completion of VTE risk assessment tool is poor, but the prescription of VTE prophylaxis is good, which is encouraging. Next slide. But obviously there's massive improvements, and I think these have all been covered already. First of all, we've got absolutely no evidence whatsoever whether Scotland's doing well with VTE prevention. You know, is VTE prophylaxis being given when it should be given? What's the incidence of healthcare associated venous thrombosis? We have some idea from one health board, but we really don't know what the size of the problem is, and also how we compare to other devolved nations. I really wish we could do better with root cause analysis of healthcare associated venous thrombosis. We really need to look for alerts for reassessment in electronic prescribing, and the electronic prescribing in its current form has been a little bit of a setback. And I think we desperately, as everyone else has said, need improved resources. There's been a real full investment in clinical governance in health boards, and that has led us to struggle. And I think that's my last slide. So thank you very much, and very happy to take any questions.
Thanks, Catherine. That was quite a wake-up call, I think, and very thought-provoking, because we are nearly 15 years on from when we started all of this, and you'd worked at King's, and I think had transported quite a lot of what was happening in England to Scotland in those early years. But I think no doubt it's a difficult ecosystem at the moment, you know, to kind of ensure that VTE prevention, you know, is prioritized, because we are still seeing the cases of hospital-associated thrombosis in large numbers. And if you're not looking, or if the system is not looking, you might not be aware of them. Again, there's in the Q&A, someone's saying that as a junior, I hated sequence. Now I wonder whether we should bring them back. But I think one thing that I find quite positive is whenever CQC visits the King's sites, they always ask to look for the VTE risk assessment figures, you know, be it on the medical wards or in maternity. So I think there is that awareness. Beverley?
I want to say something. I was very much part, and I had to fly up to help the SPSP program. And the problem and the difference between the Scottish Department of Health and the English Department of Health is the Scottish Department of Health were not prepared for, as they put it, to tell doctors what to do. So they wouldn't mandate anything. So they wouldn't, as a department, demand that we achieved 95% risk assessment, as happened to us in 2010 in England. And I think, Roopen, if you can remember, looking back, it was the first time the Department of Health in England had ever said doctors have got to do something apart from following nice guidance. And Scotland wasn't prepared to do that or to monitor what was going on. And so, I mean, Catherine, we put in as much effort as you, or rather you put in, your Scottish teams, as much effort in promoting VTE risk assessment, but we had the managers with us because they knew if they didn't get VTE risk assessment set up, there was a financial penalty awaiting for them if they didn't deliver 95% risk assessment. So it's really important what happens at the top, I think.
I think, yeah. I mean, I think we do need. We've never had a VTE specialist nurse or anything like that went around the wards and tried to promote things. I think you need something like that, I think, to keep the kettle boiling, if you like. I really like this idea because we're so, have to think about finance all the time, is to really demonstrate that if you prevent the thrombosis in the first place, you're going to save money. I won't have to see as many patients who've had venous thrombosis and say what they've got to do in the future. It just, and all that resource to diagnose and treat a venous thrombosis and then the bleeding that happens, the cost of a VTE must be huge compared to the cost of preventing a VTE.
So NICE have done a VTE cost assessment and shown that thromboprophylaxis is very cost effective because the cost of treating VTE is quite high. There is a little comment, someone saying nurses are vital in VTE risk assessment. And I just want to say, yes, they absolutely are, because as Catherine, as you just pointed out, having a VTE lead nurse, they can make such a difference with their level of enthusiasm and training people up. So I'm going to have a look at the Q&As to see if there's anything specific for you, Catherine. Okay.
I think there's someone from NHS Lothian who says that they use the Caprini risk assessment tool, but there's a need for ongoing awareness and education. So, yeah. Yeah, so I think that's a very common kind of message is, that it's not something that we are ever going to solve for good, that the efforts need to be ongoing and continuing. And again, Haley Flavel is commenting that we have EPMA and risk assessment is mandatory. So yeah, again, you mentioned that prescription is good, but risk assessment less so. And there are some of our colleagues who are commenting that maybe we should just give everyone prophylaxis, which takes me back 20 years to what was quite a farmer-driven process at that time. But I really think individualized risk assessment is a very important part of the patient pathway and journey and consent, because these treatments are not 100% safe. There's a finite bleeding risk, and there are decisions also about cost effectiveness in the current environment. So again, I'm aware of time, and I think there's 2 or 3 things I would like us to cover. One is maternity, second is mental health, and maybe the lower limb immobilization if we get a moment.
Yes, Roopen, would you like to just summarize where we are with obstetric care?
Yeah, with obstetrics, we have a very powerful process to look at maternal mortality through Embrace UK. And, between 2020 and 2022, there were 45 maternal deaths from venous thromboembolism out of about more than 2 million maternities. So it's a leading cause of maternal death. But what is particularly concerning is that this is occurring despite an extensive risk assessment process and despite extensive prescribing of low liquid heparin thromboprophylaxis. So really, where do we go next? So the RCOG produced these green top guidelines, 37A, which was last published in 2015, is being updated this year. So I think there's no doubt that every maternal death is a big, big tragedy. But I think if we can identify in a more consistent way the women at risk, then I think that is the direction of travel. And again, I think there's little doubt that risk assessment is an individualized and dynamic process through the course of the pregnancy, that currently low molecular heparin is the agent of choice. And we know that the risk begins early in pregnancy, so it's important to risk assess early in pregnancy. And again, within the EMBRACE data, nearly a quarter of the women died in the first trimester. So I think there's issues around timely risk assessment, as well as issues around ensuring delivery of thromboprophylaxis early. So one of the recommendations from EMBRACE, again, was to restructure the existing risk assessment tool to ensure that it's clear and accurate. It includes the factors that do come up during the pregnancy or postpartum, and be based on research evidence again, which is perhaps a very challenging part of that. So this committee that is revising 37A, in fact, are just about to publish a commentary in the British Journal of Obs and Gynae to look at a potential way forward. Because there's been a lot of feedback that the current risk assessment tool is over complex and difficult to implement. And in fact, there was a recent survey of healthcare personnel in obstetrics and maternal medicine that asked them, what is the risk of VTE in pregnancy? And someone commented it was 33-34%. Again, they asked, what is your threshold for antenatal and postnatal thromboprophylaxis? And people said, 27% VTE rates. So clearly, I think there's an education piece. So I think what the committee is proposing is antenatally to focus on ensuring the women with the strongest risk factors get prophylaxis, and also mechanisms are in place for to robustly ensure that it started early. And again, the kind of risk threshold that is quoted is about 1 to 2%, and a true kind of shared decision-making process and early and repeated risk assessment, I think, to make sure that we are aware of the risk. Postnatally, again, the likely proposal is going to be of, using an evidence-based multivariable model, like, for example, the Sultan model published in 2016, I think, because again, a group that Beverley was part of, which is Pandor publication, looked at the different risk assessment tools, and they did not find anything, was truly good, at taking the variability out of the decision-making process. So I think the Sultan tool is the best that's around at the moment. And I think there will need to be a big focus on sharing information, sharing the absolute risk, and shared decision-making with patients. And allied to that, what is being proposed is a big national audit of the kind of risk assessment of the low molecular heparin, prescriptions and to evaluate the effectiveness and harm, beyond maternal death alone. So it's a big, big challenge. And I think it's a huge thing to implement because our COG 37A from 2015 is really very well embedded in practice. And there are people all over the world who also use the Green Top Guideline and follow it. So I think that's all I'll say about that process. But certainly I think the commentary should be out in BGOG in the next week or two. So,
can I just add to that, Roopen? I'm working with the Department of Health to enable the guidance to have effect. And so we are having to do things like, well, we recognize there are a number of women who have high-risk pregnancies. They've already had VTE, and they find it very difficult to get anyone to prescribe low molecular weight heparin. The GPs often won't do that. So we're having to have discussions with general practitioners, and I hope that they will result in the fact that they will prescribe low molecular weight heparin. And then there's that gap when you from getting pregnant to getting obstetric care. A lot of the deaths in embrace were in women with hyperemesis before they even reached obstetric care. So we need to do something there. And the other area where there's no thinking at all is in abortion care. So we have 600,000 deliveries a year in the UK, but we actually do 250,000 terminations. And Thrombosis UK will work with the abortion clinics to try and help them get a VTE risk assessment tool and some guidance. But of course, based on virtually no evidence, we all need to do more research about pregnancy and the areas around it.
No, completely. I think that TOP issue is probably one of my most frequently asked questions in a working week, from the TOP clinic usually. But you're right. I think, we need to ensure that the women at highest risk, such as those with previous VTE or those with hyperemesis and admission, do get prophylaxis promptly. And really, the current tool is overcomplex. And I think it's sometimes difficult for the junior most people to understand and implement, the difference between quiescent inflammatory condition and an active inflammatory condition, and these comorbidities and, how do 3 or 4 risk factors interact to mean that you need antenatal prophylaxis. We had done an audit and nearly 46% of women were eligible for postnatal prophylaxis using the current guidance. And we know that the majority of them don't comply, So I think it's a big, big task. And in recognition of that, I think we have a couple of psychologists on the committee to help, with the shared decision-making piece, because, on the one hand, the VT deaths seem to be going up. And on the other hand, you are saying not just give everyone more prophylaxis, but to better target the prophylaxis to those at highest risk and ensure that they get it as early as possible, And postnatally, when, postpartum, there's more time for like a committee decision on the ward, you can then implement a more complex evidence-based tool like the Sultan tool. So,
thank you, Roopen. Can we invite all the other panel members to put their lights on again and pull you back in? I'm just very conscious of time and looking at the questions in the list. There's a very topical question. So listening to the radio this morning, there's big discussion in emergency medicine that there are now 1 million over 60s waiting more than 12 hours in the emergency department on trolleys. And there's some very pertinent questions to that in the chat, in the questions, and saying, what shall we do about VT risk assessment and giving thromboprophylaxis to people waiting on trolleys in the emergency department. This has been described as an NHS England problem. I'm sure it isn't just, but Ethel, do you want to pick up on that? What do you think we should be doing?
Thanks, Beverley. Yeah, it's quite a shocking figure. And I mean, I do think they should be risk assessed once they are admitted, whether it's on a ward or not. If they're waiting on a trolley to be seen or admitted, then they should be risk assessed. However, the realities of care in ED or in any area, it's very, very difficult. And to try and mandate something like that, it is, whilst it does need to be done, the fact that they're on trolleys, there's an issue. So it's such a difficult one, but I do think they should be risk assessed whilst they're waiting. Patients are waiting a very, very long time in ED and they're unwell. Therefore, they're at such a significant risk. So yeah, I think it is one of those that really needs a lot of discussion and review and how it's done, because it is a huge risk.
Yeah. Okay, maybe you might want to talk to the Department of Emergency Medicine. Maybe Thrombosis UK can help you with that. Maybe Roopen can help you with that as head of the VT Exemplar network. Does anyone else have any comments? Catherine, do you see people lying on trolleys in the emergency department?
Right, so yeah, it's just as much an issue in Scotland, and I think it's not just about VT prevention; it's about everything. No one, whether you don't get antibiotics or whether you don't get fluids, no one should be waiting to be seen by a doctor for that amount of time. And if they weren't making that amount of time, then VT prophylaxis would be prescribed sooner. So I think it's a much, much bigger picture than that. I think we've got to get rid of 12-hour waiting times for the over 60s being on trolleys. It's a little bit different if you're there with, some minor wound on your finger, but I think that when you're a seriously unwell medical patient, we sometimes have 17-hour waits. So it's a real issue.
I don't think they're not seen by a doctor. It's just there isn't a bed, and they have complex needs, and it takes longer to sort out than the 4-hour wait as well. So there's that too.
And once that it's so a lot of prescribing in ED is actually not done on our electronic prescribing system, so they then won't get VTE prophylaxis. So whether it's being seen by a doctor or whether it's actually waiting to be seen by a doctor, for us it would be that point of electronic prescribing, which actually might not happen until you're on a ward. So it could end up being even more of an issue.
Sue Bacon has just written that in her hospital, the admitting team actually clerk them in on the trolley. So there is an opportunity there. Whether everyone does that, I don't know. Gary, do you have that problem in Northern Ireland?
Yeah, absolutely. I think it's the same as everywhere else. I think the challenge is we've often called it inpatient VT risk assessment, and it might just be a frame shift in what we're referring to as inpatient. Because I don't often think that ED are referred to or considered to be inpatients. Our electronic system will have them logged for admission, and they're kind of in this limbo system until they get a ward attached to them. And then whenever the ward and they're transferred in, then the whole admission clicks in with regards to the Cardex and everything. So I think it might just be defined inpatient. It may be interesting to see about the hospital-acquired VTE for those patients in ED who are turned around and actually end up going home. And what proportion of those end up with a VT, and it may focus ED a little bit more on all of the patients that they're actually seeing and assessing whether they are admitted or whether they're sent home.
Thank you. Christine, is it a Welsh problem too?
Yeah, of course. I think we're a similar boat to everybody else.
Okay. I'm just looking, there's a comment. Though not over 60, I've twice had to wait to be seen by a doctor in A&E, dehydrated and vomiting in early pregnancy. Forgot about VTE prophylaxis. Fluids might have been nice. So there we go. Hyperemesis, not really recognized as VTE risk by the patient, and delivery of fluids was difficult. Roopen, can I hand back to you the discussion about day wards and the fact that certainly in NHS England, we've moved 80% of ops to be day ops. Back when we started in 2010, most procedures in the day ward were a little cut finger and things like that. Now we're doing, well, I know you do at King's, you do knee replacements. We do knee replacements in day ward, cholecystectomy, even a mastectomy in day ward. And one really worries about VTE risk assessment.
Yeah, I think it is a significant issue. To those of you who were involved early on with the VTE prevention program, we had defined several cohorts, of various day cases that were considered low risk and declared as such in the risk assessment. But I think this is, in the past 5 or 10 years, that there has been a big change in practice towards day surgery. So, really, we don't know what is the right thing to do, or there's not been a change in the systems, because in the old days, they used to give people stockings, wear stockings for a day, which achieve absolutely nothing, or give them a single injection of low liquid heparin, again, which will achieve very little. So I think it's an area we need to focus on. Yeah. And again, I think we did get that signal when we looked at that national mortality data that we published about a year ago. So I think it's an area. So, I mean, the other area we need, which is also pretty evidence-free, is mental health. Do you want to comment on that? I know you had kind of published the outcome of your survey recently. Which,
So looking at psychiatric hospitals in the UK, a lot of them are doing VTE risk assessment. They've made up their own tools. No one's quite sure what the risks are. And we know that there's a definite VTE rate in patients post-discharge after psychiatric admission. Your colleague, Laura Roberts, is hopefully going to provide us with some data on the rates of VTE. And the Irish are doing some national guidance on what we could perhaps do for thromboprophylaxis in the patients in mental care wards. Shall we end on a positive note? Why don't we talk about stockings? Roopen, do you want to talk about stockings?
No, I can't deprive you of the opportunity to comment on, the ever-dwindling evidence supporting the use of stockings. I think clearly, in medical patients, we shouldn't be using it. In obstetric patients, we shouldn't be using it, and NICE don't tell us to use it. So there's still some residual usage in that area, recent surveys indicate. But I think even in surgery, which has been the bastion for use for decades, I mean, the evidence is getting weaker and weaker that stockings add anything to pharmacological thromboprophylaxis. And in the current parlous economic circumstances, to be using something which has so little evidence to support it, is getting increasingly difficult. Beverley?
So we've done the GAP study, which shows in moderate risk surgical patients, there's no benefit of anti-embolic stockings if you're already taking low molecular weight heparin. And then we're doing the PET study, which is low risk surgical patients, so day ward cases essentially. We were going to randomize 22,000. We've stopped the study at 11,000 because we have an answer. We think the answer says they have no benefit, and we will be publishing that in the autumn. And then we have one further study looking at the use of stockings in extended thromboprophylaxis, and they will receive pharmacological thromboprophylaxis and then a stocking or no stocking. That's hip and knee replacement. So exciting times. All the evidence is coming from the UK. I think we're going to say anti-embolic stockings have no benefit, only harm. Now, I'm going to end there. Does anyone else have anything else they want to say? No, I think that's it. So what a wonderful team we've had. Thank you, Catherine, Ethel, Gary, Christine. A special thanks to Roopen. Roopen, do you want to summarize everything? And
I think it's been a great discussion and quite sobering in many ways. That, you know, there's a lot that has been done, but a lot remains to be done, I think, to keep up these efforts, you know. And it's probably better to hear it as it is so we can do something about it. So, and I'm aware, just looking at the names of the people on the chat as well, there's many of the champions of VTE prevention nationally. So just thank you for all that you do. And just lastly, you know, thanks to the expert faculty for their contributions, and biggest thank you to Joe and to Thrombosis UK for all your efforts, you know, and putting on this wonderful webinar. So thank you.